Hello everyone. Welcome to NEET-PG 2023 recall session by ADrPlexus. I am Dr. Chandini and I am going to recall certain MCQs that has come in the pediatrics part in NEET-PG 2023. So we'll go on to the first question. So the first question that was asked was, a 3-year-old child presented with fever and stridor with history of prior upper respiratory infection. So what is the diagnosis based on the X-ray given below? So they have given an X-ray and they have asked for the diagnosis. So if you see that X-ray here, you can see some narrow part. So what is this? What is this? This is called as steeple sign. This is called as steeple sign. This steeple sign is seen in, is it seen in epiglottitis? Is it seen in acute laryngotracheal bronchitis or foreign body or laryngomalacia? So the answer here is ALTB, that is acute laryngotracheal bronchitis, also known as croup. So steeple sign is seen in acute laryngotracheal bronchitis, also known as croup. So what about the other options? What do you see in acute epiglottitis? What do you see in foreign body and in laryngomalacia? So now we'll see that. Now, if you see the first image, so this is what is given in the question. This is the steeple sign. So what is steeple? Steeple is nothing but this pointed part of the church, right? This is called as steeple. So this looks like a steeple. Why is it like that? Because it is due to the narrowing of trachea. This steeple is due to the narrowing of trachea, which is seen in ALTB. That is why it is called as steeple sign. Now, what about this X-ray, the second X-ray? Can you see here? So this is a lateral X-ray of the neck where you can see a thumb-like sign. So this is called as thumb sign. So where do you see thumb sign? Thumb sign is seen in acute epiglottitis. Thumb sign is seen in acute epiglottitis. So in ALTB or croup, you see steeple sign, and in acute epiglottitis, you see thumb sign. Okay, clear with the first question? Now, coming to the next question. A child presented with dermatitis, alopecia, with history of raw egg ingestion. What is the probable vitamin deficiency? So what they are given, they are given the scenario as the child is having dermatitis and alopecia. And the clue that is given here is raw egg ingestion. So what does raw egg ingestion have to do with dermatitis and alopecia? Now, raw egg contains a particular substance called as avidin. So this avidin is with the absorption of biotin. So biotin is a vitamin, right? So avidin interferes with the absorption of biotin. So what you have, you do not have biotin in the body. So you will have biotin deficiency. So what are the features of biotin deficiency? You will have dermatitis, you will have alopecia and glossitis. Dermatitis, alopecia and glossitis. These are the features of biotin deficiency. So here the answer is nothing but biotin deficiency. Whenever you see raw egg, you think of biotin deficiency. Why is it due to? Because of avidin. Okay. So this is the answer for the second question. Now coming to the third question. The third question was, a child present with history of developmental delay. So on examination, there was cherry red spot on the macula. Cherry red spot is there on the macula and there is no hepatosplenomegaly. What is the diagnosis? So the options given were Niemann-Pick, Goucher, Tay-Sachs and Hunter. We all know all these four are what? All these four are lysosomal storage diseases. Okay. Now, if you see here, inborn errors of metabolism. If you see here, they are given, the child is having cherry red spot. Cherry red spot on the macula. So one point you have to remember is all these diseases, they have cherry red spot except for two diseases. One is your Goucher. No cherry red spot in Goucher and Crabbies. So Groucher and Crabbies, they don't have cherry red spot. So what? Goucher's disease is ruled out here. Now, the second thing they have given is hepatosplenomegaly. They have told that the child is not having hepatosplenomegaly. So no hepatosplenomegaly. All these inborn errors, they have hepatosplenomegaly except for two diseases. One is your Crabbies and one is your Tay-Sachs. So Tay-Sachs does not have hepatosplenomegaly. So what is the answer? Here the child is having cherry red spot, but no hepatosplenomegaly. So the answer is nothing but Tay-Sachs disease. So Tay-Sachs disease. What is Tay-Sachs disease? Any idea what is Tay-Sachs disease? Tay-Sachs disease. Tay-Sachs disease is GM2 gangliosidosis. GM2 gangliosidosis. What is other GM2 gangliosidosis? Sandhoff. Sandhoff is another GM2. The first thing is Tay-Sachs, the next GM2 is Sandhoff. So what happens here? There is a deficiency of beta hexosaminidase A. Beta hexosaminidase A is deficient. So the child will have features like cherry red spot. What are the features? One is cherry red spot. Then you will have neurological deficits. Macrocephaly. What is macrocephaly? Large head. Macrocephaly. And they will also have exaggerated startle reflex. This is important. Exaggerated startle reflex. So these are the features of Tay-Sachs disease. But they will not have any visceromegaly. They will not have any organomegaly. Okay. So this is about Tay-Sachs disease. Now, going to the next question. The next question was, they have given an X-ray that was similar to this, and I've asked the scenario. A 2-month-old infant presented with swelling over the scalp since birth. 2-month-old infant. So the clue here is that a baby is 2 months old and the baby is having some swelling since birth. So what is the diagnosis based on this X-ray? So as you see here, you can see a swelling in the X-ray where the swelling is somewhere in the parietal area. And what is the plane? So it is above the bone. It is not something to do with the bone. Can you see? So the plane is somewhat subperiosteal. Okay. So now, what is the diagnosis? Is it encephalocele? Is it cephalometoma? Is it caput secundinum or subgaleal hemorrhage? So what is the diagnosis here? Now, the actual answer here is nothing but cephalometoma. So how to identify this? So what is cephalometoma and what is caput? Okay. Now we'll see these images. Can you see the first image? So in the first image, there is a uniform swelling, right? So this is nothing but caput. So both these images are of newborn babies. So the first image is nothing but caput. Now coming to the second image. Here you see a localized swelling which is confined to one area. Okay, what is this? This is nothing but cephalhematoma. Cephalhematoma. Now, how to differentiate? What are the differentiating features of caput and cephalhematoma? So if you see here, caput, what is caput? It is a edematous swelling. Okay, it is a edematous swelling. This occurs due to the process of birth. During the process of birth, the baby will develop the swelling. And what is the plane? The plane is subcutaneous. The plane is subcutaneous. What about cephalhematoma? Cephalhematoma is, what is the plane? It is subperiosteal. Subperiosteal plane. Okay. And what is the content? It is hemorrhage. It consists of blood. So it is a subperiosteal hemorrhage. Okay. Now this caput, it can be seen at birth. It will be present at birth itself. Whereas this cephalhematoma, it will take at least 12 to 24 hours of birth to form. Okay. Now, caput usually resolves by 1 week. Caput usually resolves by 1 week. Whereas cephalhematoma, it will take at least 3 to 4 weeks to resolve. It will take at least a month to resolve. Now, the last point, this caput, as it is just edema, it can cross the midline and sutures. It will cross the midline and suture. Okay. Whereas your cephalometoma, they cannot cross midline. That is why it is a localized swelling. They cannot cross midline and sutures. So with these points, we can know that this X-ray is nothing but cephalometoma. Why? Because the first point, it is localized in the parietal area. The next point, in the history, they have seen that it is a 2-month-old baby. If it's a caput, it would have been disappeared by now. Whereas this cephalometoma is still present. Okay, so this is nothing but cephalometoma. Okay, clear? Now, going to the next question. A mother delivered a baby at 31 weeks. The neonate showed features of respiratory distress syndrome with X-ray showing ground glass opacities. Which among the following substances deficient? So this is a direct question. They have told that the mother has delivered a preterm baby. So any baby which is delivered before 37 weeks is called as a preterm baby. So this is a 31 weeker, so that is a preterm baby. Next, they are telling the preterm baby is having features of RDS, nothing but respiratory distress syndrome or hyaline membrane disease. And what is the X-ray showing? Ground glass opacities. Now, which among the following substance is deficient? So why do you get RDS in a preterm baby? What is the reason for RDS in a preterm baby? Okay. Preterm babies, they lack something called as surfactant. What is the role of surfactant? This surfactant, it reduces the surface tension of the alveoli. Surfactant reduces the surface tension of alveoli and it will prevent what? It will prevent collapse of alveoli. So, surfactant is very essential for the majority of is deficient. In other words, they're asking, what do you mean by surfactant? What is surfactant? Is it phosphatidylethanolamine? Is it lecithin or ganglioside? What is the answer? The answer is lecithin. Okay, the answer is lecithin. So surfactant is nothing but lecithin and sphingomyelin. Okay, surfactant is nothing but lecithin and sphingomyelin. Lecithin is also called as phosphatidylcholine. Phosphatidylcholine and sphingomyelin. These two are the substances that is acting as a surfactant and it reduces the surface tension. Okay. Now coming to the next question. Again, we have a scenario. What is the scenario? A child presents with fever, coryza, and conjunctivitis. They say the child is having fever, coryza, and conjunctivitis. Okay. Oral mucosa is showing Koplik spot. What is the diagnosis? So where do you get Koplik spot? Is it mumps? Is it measles? Is it chickenpox or rubella? So this is a very direct question. Koplik spot is seen in measles. So the answer is measles. What do you mean by Koplik spot? I'll show the image. So in this image, can you see here? Can you see some small white or gray nodules that are surrounded by erythematous areas? These are called as Koplik spots. So what are Koplik spots? They are seen in measles. And they are nothing but white, grainy, like lesions surrounded by erythema. Where do you see? Opposite to lower second molar. Opposite to lower second molar. That is important. The location of Koplik spot is important. And they occur on 2nd or 3rd day of measles. Will be seen on 2nd or 3rd day of measles. This is about Koplik spot. What are the other features of measles? Measles, they usually present with fever, coryza-like symptoms, conjunctivitis, and they will have a rash. What rash? It is a characteristic maculopapular rash. Maculopapular rash. So here the rash will be seen on 4th day of fever. So in measles, Usually you will see the rash on the 4th day of fever. Okay, it is a maculopapular rash. Now, what are the complications of measles? What are the complications of measles? You will have otitis media. You will have bronchopneumonia and diarrhea. These are few complications of measles. Okay, now let's move on to the next question. The next question was, it was a scenario. What they told was, it was 10-year-old boy, weight 30 kgs with severe dehydration. So telling there is severe dehydration. Ketone bodies are there in the urine. First point is, the baby is having ketone bodies in the urine. Next, blood sugar is 550 milligram per deciliter. Is it normal? No. Definitely the baby is having hyperglycemia. The third point is pH is 7.1. Is it normal or what? No, it's not normal. It is 7.1. It means the child is having acidosis. So here the child is having what? Acidosis, ketone bodies in the urine, and hyperglycemia. So what is this scenario? What is this scenario? This scenario is nothing but diabetic ketoacidosis, DKA. This is a scenario of diabetic ketoacidosis. So what is the triad of diabetic ketoacidosis? Hyperglycemia. How much? More than 200 milligram per deciliter. Acidosis. If pH is less than 7.3 or bicarb is less than 18. Next, ketone bodies in urine or ketonemia. So these three are the features of DKA. So now they have given you a scenario of DKA and they have asked for the initial management. Now coming to the options, we can see that in all the options, ABC is given. Yes, definitely ABC, airway, breathing, circulation is given in all the 4 options. Then they have given something about the fluid, how much fluid to give. Then the third part is about when to give insulin. In first option, it is given insulin has to be given as an infusion after 1 hour. Second option, they are telling that it should be given as bolus. In third also, it is given, it should be given as bolus. And the fourth option, again, it is given as after 1 hour of fluid. So now which one to select? So definitely we know ABC is the first management in DKA. Now the second management is fluid. Why? Because the child is having dehydration. So we have to correct this dehydration. So fluid is necessary. The third thing is insulin. Now, when to give fluid, how much fluid to give? That is the second thing. Next thing would be when to give insulin and how much to give. Okay. Now, the first part is ABC. Followed by ABC, you have first step is always airway, breathing, and circulation. Now, the next step, they are telling the child is having severe dehydration. If the child is having dehydration, you will give around 10 ml per kg of fluid. 10 ml per kg of fluid over the first 30 to 40 minutes, you will give 10 ml per kg of fluid. Followed by that, you will give insulin as infusion. Insulin as infusion. Okay, never give insulin as bolus or before correcting dehydration. So the first thing is ABC, followed by correcting dehydration. Then you have to give insulin infusion and not as bolus. How much insulin? 0.05 to 0.1 units per kg per hour as an infusion. So these are the steps of management of DKA. According to what? According to ISPAD. What is ISPAD? ISPAD is nothing but International Society for Pediatric and Adolescent Diabetes. So what they say is the first management, as you see here, what they are telling. First, you will take the clinical history and first management is always dehydration. Now, here what you have to see is whether the child is in shock or not. If the scenario is given as the child is in shock, immediately you have to give 20 ml per kg. Okay, 20 ml per kg of fluid and not 10 ml. So if the scenario is shock, you will give 20 ml per kg of fluid. If the child is not in shock, you will go with 10 ml per kg over 20 to 30 minutes. After that, you will give continuous insulin infusion after 1 hour of fluid. Clear? So ABC followed by fluid and then insulin as infusion and not as bolus. So this is the treatment of DKA. Suppose the same scenario is given as shock. If they say the child is in shock, then the option would be this one, 20 ml per kg, and then insulin infusion. But now they are telling the child is not in shock, it is in severe dehydration. So what is the answer here? It's nothing but ABC, 10 ml of kg for the first hour, followed by insulin infusion. Okay. So now the answer is A. Okay, clear with this? Okay. Going to the next question. Which among the following is normal in an infant? So they've asked which is normal in an infant. They're given options like length at 1 year of age plus 25 centimeters, increase in weight by 300 gram every month, and anterior frontal closes by 6 months of age. Okay, coming to the last option. Anterior frontal closes by 6 months of age. Is it true? No. When does AF close? Around 9 to 18 months of age. Clear. Increase in weight by 300 gram every month. No, it is not the same. It differs as the baby grows. Okay, it is not standard like every month the baby will gain 300 grams. What about the first option? Length plus 25 centimeters at 1 year of age. So what is the approximate length you expect at 1 year of age? At birth, the baby would be somewhere around 50 centimeters. At 1 year, baby would be somewhere around 75 centimeters. At 2 years, the baby will be somewhere around 87 centimeters. Now, as you see, how much the baby has gained? 25 centimeters in the first year, then somewhere around 12.5 centimeters in the second year. So, option A is correct. So, the baby will gain around 25 centimeters in the first year. This is about the length of the baby. Now, what about the weight of the baby? What happens to the weight normally? Normally, what happens after the baby is born, there will be a loss of 10%. 10% of weight loss in the initial few days after birth. Okay, followed by regaining of birth weight. When will the baby regain birth weight? Somewhere around 10 to 14 days. So the baby will regain birth weight by 10 to 14 days. And then the baby will start gaining around 20 to 30 gram per day. Per day, the baby will gain 20 to 30 gram per day. Then baby will doubles birth weight by 5 months. Doubles birth weight by 5 months. Triples birth weight by 1 year. Quadruples birth weight by 2 years. Clear? So this is about weight. Initially, there will be a loss. Then the baby will regain birth weight by 10 to 14 days. Then it is around 20 to 30 gram per day for the initial 3 months. Then doubles birth weight by 5 months. Triples birth weight by 1 year. Quadruples birth weight by 2 years. Clear? So this is about the weight. Now going to the next question. The triad of patent ductus arteriosus, cataract, and deafness is seen in. So they are given you a triad. What is the triad? PDA. The child is having some congenital heart disease. Next, the child is having some cataract. Next, it is deafness. So where do you see this triad? So this is a classical triad of nothing but congenital rubella syndrome. So this is a classical triad of congenital rubella syndrome. So this is the answer for this question. Okay, PDA, deafness, and cataract. Now coming to the 10th question. Another question from vitamin deficiency. They are given diarrhea, dermatitis, dementia, and death. Where do you see? 4 Ds. What are the 4 Ds? The 4 Ds: diarrhea, dermatitis, dementia, and death. So these 4 Ds are classically seen in pellagra. What is pellagra? What is pellagra? Pellagra is nothing but niacin deficiency. Pellagra is seen in niacin deficiency. So what are the other features of niacin deficiency? What is this? You see a hyperpigmented symmetrical area in the sun exposed regions in the neck. So this looks like what? This looks like a necklace, right? So this is called as Kessel's necklace. This is called as Kessel's necklace seen in pellagra. Niacin deficiency. Okay. Now coming to the next question. A baby presents with perioral rash, perianal rash with delayed wound healing. What is the deficiency seen here? Is it copper? Is it iron, zinc, or cobalt? Where do you see this classical type? Okay, this is nothing but zinc deficiency. So what are the features of zinc deficiency? So in zinc deficiency, you will have impaired growth. First is growth retardation. Next, you will have hypogonadism. Then you will have hypogonadism, impaired growth. Then you will have some features of delayed wound healing. Okay, so these are some features of zinc deficiency. Now, there is a syndrome called as acrotype. There is a syndrome called as enteropathica. Acrodermatitis enteropathica. What is acrodermatitis enteropathica? It is an autosomal recessive condition. So what happens is that there is impaired absorption of zinc. So zinc is not absorbed. There is impaired absorption of zinc. So they will have characteristic features of periorificial rashes. So what are the periorificial rashes? Rashes, the perioral area, rashes in the perivaginal area, and perianal area. So the baby will have all these rashes along with delayed wound healing and chronic diarrhea. Delayed wound healing and chronic diarrhea. These are the features of acrodermatitis enteropathica, where there is impaired absorption of zinc. Okay. So the answer for this is zinc deficiency. Now coming to the next question. Black urine is seen in. So this is a very direct and classic question. Black color urine. Where do you see black color urine? Is it alkaptonuria, maple syrup urine disease, phenylketonuria, or homocystinuria? So the direct answer here is alkaptonuria. So what is this? Alkaptonuria. What is alkaptonuria? What is alkaptonuria? It is an inborn error of metabolism due to deficiency of an enzyme called as homogentisate dioxygenase. Homogentisate dioxygenase. So what happens if you don't have this enzyme? Some bodies, some benzoquinones are excreted in the urine, which on exposure, see, can you see here? Initially, when the child is passing, the urine will be clear, but on exposure to air, it gets converted to some alkaptone bodies, and it gives this characteristic black color urine. So darkening of urine on standing or black color urine is a characteristic feature of alkaptonuria. What are the other features of alkaptonuria? Other features are nothing but arthritis, grayish discoloration, gray or black discoloration of this nose, pinna, and all, because of accumulation of these bodies. And you have something called as ochronosis. What is ochronosis? Deposition of these materials in the intervertebral disc. So this is ochronosis. All these are features of alkaptonuria. Okay. So what about the other options? What is maple syrup urine disease? Wait, what do you see in maple syrup urine disease? In MSUD, you see maple syrup order. Maple syrup order. What about phenylketonuria? You see mousy order. What about homocystinuria? There will be increased level of homocysteine in the urine. Okay. So the answer here is alkaptonuria. Now, Coming to the next question. They are given an image like this and I have asked for what deficiency is this. So what is this? What is seen in this image? There's some bowing of legs is seen. So where do you see bowing of legs? This otherwise called as genu varum. Bowing of legs is called as genu varum. Where do you see bowing of legs? It is seen in rickets. Rickets is due to what? Vitamin D deficiency. So the answer is vitamin D deficiency. Bowing of legs seen in rickets. Okay. So what are the other features of rickets? What are the other features of rickets? From head to foot, what all do you see? You will see something called as craniotabes. What is craniotabes? Softening of your skull bones. That is called as craniotables. Then you will have open anterior fontanelle. Then delayed dentition. Delayed dentition. Then coming to the arms and all, you will have deformities like your genu varum, genu valgum. What is genu valgum? Genu valgum is knock knees like this. This is genu valgum. This is genu varum. Okay. And you will have some abnormalities and in the extremities and bone deformities. Then you will have quad belly. All these are some of the features, head to foot features of rickets. Okay. So what do you see in X-ray? In X-ray, you will see cupping and fraying of long bones. Cupping and fraying of long bones is seen in X-ray. Okay. So this is about rickets. Coming to the next question. A 10-year-old child, what vaccination would you recommend according to National Immunization Schedule? So we have two schedules in immunization. One is the National Immunization Schedule and next one is the IAP. IAP is Indian Academy of Pediatrics. So the one that we follow in government setup is National Immunization Schedule. So when a child comes to you, a 10-year-old child comes to you in a government setup, according to National Immunization Schedule, what vaccine would you give? Is it BCG? Is it TD? Is it DPT or typhoid? So the answer here is TD. What is TD? Tetanus and diphtheria. So now coming to National Immunization Schedule. So knowing National Immunization Schedule is very important. Okay. Now, at birth, what are the vaccines you give at birth according to National Schedule? BCG, OPV 0 dose, then hepatitis B. So this is given at birth. Next comes your 6 weeks, 10 weeks, 14 weeks. Okay, 6 weeks, 10 weeks, and 14 weeks. In 6 weeks, you will give penta dose 1, pentavalent. What is pentavalent? Pentavalent means 5. Pentavalent consists of 5 components: diphtheria, pertussis, tetanus, hepatitis B, H, influenza B. Okay, so these 5 are components of pentavalent. So you will give pentavalent 1, then you will give OPV 1, then you will give Rota 1, followed by FIPV. FIPV is fractionated dose of IPV 1, and you will give PCV 1. Okay, totally 5. This is given at 6 weeks. Now coming to 10 weeks. 10 weeks you will give only Penta 2, OPV 2, Rota 2. You will not give this FIPV and PCV in 10 weeks. Okay. Now coming to 14 weeks. 14 weeks is same as 10 weeks. Both are same. So same. You will give Penta, which dose? Third dose. OPV, third dose. Rota, third dose. FIPV, second dose, and PCV, second dose. Clear? 6 and 14 weeks are same. Okay. Now after this, next is 10 months, around 10 months. 10 months you will give MR vaccine. What is MR? Measles and rubella. Then what you will give? PCV booster you will give. Then FIPV third dose. This is important. This FIPV third dose in 10 months is recently introduced from January 2023. So FIPV third dose is given at 10 months. In some endemic districts, they will also give Japanese encephalitis. It not in all districts, only in some endemic districts. That is 10 months. Next comes the 18 to 24 months. Same. 18 to 24 months, you will give DPT booster, MR second dose. Then, if at all you give JE, you will give JE second dose. Then OPV booster. Okay, all booster doses are given at 18 to 24 months. After this, directly 5 years. 5 years, you will give another DPT booster. Next, 10 years and 16 years. 10 years and 16 years, you give TD. Okay, T and small d, TD. So this was the question asked. So 10 years, you give TD. So this is the national immunization schedule, which you should know by heart. Okay, going to the next question. A neonate presents with hepatosplenomegaly, hearing loss, and periventricular calcification. See, they are given an image. And these are the ventricles. Here you can see some dot. Okay. Can you see these white dots? They are nothing but calcifications in which area? In the surrounding the ventricles. So that is why you call them as periventricular calcifications. So where do you see hepatosplenomegaly, hearing loss, and periventricular calcification? So this is classical example of congenital CMV infection. So this is classical example of congenital CMV infection. So what are the features of congenital CMV infection? You will have hepatosplenomegaly, hearing loss, and periventricular calcifications. Do you see calcifications in some other taunch infection? Intracranial calcifications. Where do you see? In toxoplasmosis. In toxoplasmosis, you will see intracranial, but they are not periventricular. They are distributed throughout the cortex. It is not specific to periventricular area. They will have intracranial calcifications. So what about torch? In toxoplasmosis, you will have a triad of chorioretinitis, intracranial calcifications, and hydrocephalus. So this is the classical triad of toxoplasmosis. Whereas in CMV, you will have periventricular calcification. Clear? Now, going on to the next question. So the next question is somewhat, they've given an image and they've asked which enzyme is deficient in this. So this is a bone marrow image, okay? It is a bone marrow image. So if you see, can you see a structure here? So this is nothing but a macrophage, but it looks like what? It looks like a crumpled tissue paper. If you crumple a tissue paper and see, no. So this looks like a crumpled tissue paper. So where do you see crumpled tissue paper in bone marrow biopsy? So this condition is nothing but Gaucher's disease. These cells are nothing but Gaucher cells. Okay, so the answer here is Gaucher's disease, but they've asked the enzyme deficiency. So what is the enzyme that is deficient in Gaucher's disease? What is the enzyme? Enzyme is glucocerebrosidase. So the enzyme that is deficient in Gaucher's disease is glucocerebrosidase. Okay. Now then, what else will you see? You will see something called as Erlenmeyer flask deformity in X-ray. Erlenmeyer flask deformity in X-ray. Then one more important thing, Gaucher's disease was the first disease to have enzyme replacement therapy. Okay, Gaucher's was the first lysosomal storage disease to have enzyme replacement therapy. So what is it known as? Velaglucerase or imiglucerase. Imiglucerase. These are the enzyme replacement therapy options available for Gaucher. And it also has substrate reduction therapy. that is called as Miglustat. Okay, so this is important about Gaucher's disease. Gaucher's disease is being repeated for the third time this year. Now, coming to the next question. Here they are given some scenario. A 3-month-old baby presents with fast breathing. They're just given the child is having fast breathing. Which antibiotic would you prefer for home management? Okay. So now what I have asked here is something called as IMNCA. Any idea about IMNCA? IMNCA is nothing but integrated management of neonatal and childhood illness. So they have given certain guidelines for how to diagnose and treat certain conditions. So this IMNCA is mainly for health workers in the primary centers, health workers who are going and seeing the baby. So how will they identify whether the baby is sick? When should they give home medicines and when should they refer? So that is what is given in this IMNCA. So according to this IMNCA, they will divide the babies into 2 categories. The first category would be sick infants. Sick infants means less than 2 months of age will come under this category. The next category would be 2 months to 5 years of age. Here they will called as sick children. Okay. So based on this, they will give certain guidelines for so many conditions like diarrhea and for pneumonia, for jaundice, malaria, and they have so many prefix guidelines and rules which has to be followed. Now they ask, according to this, if a baby has fast breathing, which antibiotic will you give for home management? Okay, according to IMNCI, you will prefer amoxicillin. Okay, the answer here is amoxicillin. So, but what will you do? You will see whether the child is having cough and cold. So, if the child is having cough and cold, the next step what they will do is, they will see whether the child is having any features of warning signs. Okay, like refusal of feeds, lethargy, all these are warning signs. If the child is having warning signs, this is indicated as pink area. So according to pink area, what they will do, they will give first dose of IM antibiotics, intramuscular antibiotics, and they have to refer to higher center. So that is about the pink zone, first zone, if the child is having warning signs. Second, if they are saying cough and cold is there, the child is not having any warning sign, but there is fast breathing alone. Child is having fast breathing alone. Then what to do? The second zone. This second zone is nothing but your yellow zone. So according to this yellow zone, what they will do, they will give antibiotics, oral antibiotics. Which antibiotics? Amoxicillin. They will give oral amoxicillin and send the baby home, and then they will ask them to review in few hours, 24 to 48 hours, and review, follow up. Okay, that is this yellow category. Now, suppose the child is having cough and cold, but child is absolutely normal, no other problem, means what they will do, they will directly come into this green zone. So in this green zone, what they are doing is, they will advise home treatment and home management, home remedies. They will not give any medicines. They will just reassure the mother and send the baby home. Okay, so according to this, where this baby is coming under this fast breathing yellow zone, so they will give what antibiotic? They will give amoxicillin and send the baby home and ask them to follow up. Okay, so this is the answer for this question, IMNCI. Okay, so now with this, we have completed most of the MCQs that has been asked from Pediatrics and NEET-PG 2023. Thank you.